It's just taking its time. All right, so at least 3.2 billion of the world's population are still at risk of contracting malaria. This is almost half of the world's population, as we are sitting at 8.1 billion at the moment. In 2022, there were an estimated 249 million malaria cases worldwide, with 94% of them occurring in the African region. 608,000 cases ended in death, with 95% of those deaths occurring in Africa. Malaria is preventable and curable, and most people who have malaria experience rapid resolution of symptoms with adequate treatment. However, severe illness with significant complications may occur, including cerebral malaria, coma, or death. Infants, children under 5, pregnant women, travelers, and immunocompromised patients face a higher risk of severe infection, with children under 5 years of age accounting for about 78% of malaria deaths in our region. As one can see from the statistics above, malaria is a major global health concern, especially in sub-Saharan Africa, and causes huge social and economic burdens on malaria endemic areas due to its high morbidity and mortality rates. Malaria is the sixth leading cause of death in low-income countries. Lack of resources and money and political instability can prevent the sustainability of malaria control programs. And malaria parasites are becoming more resistant to antimalarial drugs, and insecticide resistance in vectors is also increasing, which is presenting another problem for malaria control. What is malaria? It is a potentially life-threatening infectious disease caused by parasites of the Plasmodium genus. It is primarily transmitted to humans through the bite of an infected female Anopheles mosquito. There are approximately 156 named species of Plasmodium, but only 4 of them are considered true parasites of humans, as they utilize humans almost exclusively as natural intermediate hosts. These 4 species are P. falciparum, P. vivax, P. ovale, and P. malariae. There is a 5th species in Southeast Asia called P. knowlesi that is becoming more prevalent and is now the main cause of human malaria in Malaysia and some regions of Brazil. It causes a zoonotic malaria, which means that it's spread by wild non-human primates to humans. The overwhelming majority of worldwide morbidity from malaria is caused by P. falciparum, followed by P. vivax. So if we look at the life cycle of malaria, it's really important to know because it helps us understand some of the pathophysiology. It involves complex interactions between the Plasmodium parasite, the Anopheles mosquito, and humans. If we look at number 1 at the top, basically a malaria-infected female Anopheles mosquito takes a blood meal by inserting her proboscis into human skin and ejects up to about 100 sporozoids per bite with her saliva. The sporozoids then travel through the blood and enter liver cells to get to the human liver stage. This is where they undergo asexual reproduction and mature into liver schizonts. After 7 to 30 days, depending on the species, each liver schizont ruptures and releases about 2,000 to 40,000 merozoites. It's important to know that species like P. vivax and P. ovale can lie in a dormant stage in the liver and cause relapses by invading the bloodstream months or even years later. Then we move on to the human blood stage. So if you look at number 5 on the right-hand side, it's basically where the merozoites infect red blood cells. They digest the hemoglobin and mature into ring-stage trophozoites. Trophozoites can then follow 2 paths. So if you look at the black arrows, this is where they undergo asexual reproduction to form a red blood cell schizont that then ruptures and releases more merozoites, which will invade more red blood cells and continue that process. The rupturing of the schizont is basically what causes the classical malarial paroxysms every 2 to 3 days. So this is erupt episodes of high fever, rigor, and diaphoresis, and then a normalization of the temperature. The second pathway is where the trophozoites change into male and female forms called gametocytes. These are ingested by the female Anopheles mosquito during their next blood meal. I won't go into too much detail as it's quite complicated, but basically the gametocytes undergo sexual reproduction and eventually form oocysts, which grow and rupture and release sporozoites. The sporozoites then migrate to the salivary glands of the female Anopheles mosquito, and they are ready to be injected into the next human and basically undergo the cycle again. So where is malaria found? The prevalence of malaria depends mainly on climatic factors such as altitude, temperature, humidity, rainfall, and proximity to bodies of water. In general, malaria transmission is highest in areas that have higher temperatures, high levels of humidity, and high rainfall. Therefore, malaria is transmitted mostly in tropical and subtropical areas where Anopheles mosquitoes are able to survive and multiply, and malarial parasites have an abundance of hosts in which they are able to complete their life cycle. Temperature is especially important. For example, P. falciparum cannot complete its growth in the Anopheles mosquito at temperatures below 20 degrees and thus cannot be transmitted. In many malaria endemic countries, malaria transmission does not occur in all parts of the country. Even within tropical and subtropical areas, transmission will not occur at very high altitudes, more than 1,500 meters, during colder seasons and in deserts, excluding the oases. If we look at this map, generally the warmer regions closer to the equator, that's where transmission will be more intense, and malaria is usually transmitted year round. The highest transmission is found in sub-Saharan Africa, parts of Asia, parts of Oceania, such as Papua New Guinea, and parts of Central and South America. In cooler regions, transmission will be less intense and more seasonal. In many temperate areas, such as Western Europe and the United States, economic development and public health measures have succeeded in eliminating malaria. However, most of these areas still have Anopheles mosquitoes that can transmit malaria, and so reintroduction of the disease is a constant risk. It is important to note that the present distribution and prevalence could start to change due to climatic changes like global warming, as well as population movements. I'll go into more detail later about high risk and what chemoprophylaxis is needed, but this is just to show more of the year-round transmission areas as well as the seasonal areas. If we move into South Africa, malaria transmission is seasonal, with cases starting to rise in October, peaking in January and Feb, and waning towards May. Malaria is mainly transmitted along the border areas. So areas of Limpopo, Mpumalanga, and KwaZulu-Natal are endemic for malaria, and 10% of the population, which is approximately 4.9 million people, are at risk of contracting the disease. The increased influx of people from neighboring countries that are endemic for malaria also means that we have to have a high index of suspicion in patients presenting from those areas with signs and symptoms in keeping with malaria. We also get occasional instances of infected mosquitoes that are accidentally transported to non-endemic areas and transmit malaria. So this is a form of the disease called Odyssean, or other names such as taxi, suitcase, or airport malaria. And Gauteng is at high risk of this because we have a very large and mobile population. If we look at the clinical presentation and severity, it can vary depending on the species of malaria parasite, the individual's immunity, and the presence of any underlying health conditions. The most important thing to ascertain in any patient that's presenting with suspected malaria is whether they have a recent travel history to endemic areas, especially in the last 3 months, but you may want to ask even up to a year because of the two species, especially that I spoke about earlier, P. vivax and ovale, that can lie dormant in the liver. In our population, think about any travel from more endemic areas such as Mpumalanga, Limpopo, and KZN, as well as our neighboring countries such as Mozambique that are endemic for malaria. It's also important to get information such as patient's age, immune status, pregnancy status, allergies, or other medical conditions, because this can affect severity. Pregnant women, children under 5, and immunocompromised patients, so those that have HIV, are chemotherapy or are using immunosuppressant doses of corticosteroids, are at high risk for developing severe malaria. So patients with uncomplicated or non-severe malaria usually present with very non-specific flu-like symptoms. They may present with this very, what they describe in the literature as malarial paroxysms, which is these 2 to 3 day cycles of high fever, rigors, and diaphoresis, and then a subsequent waning of the symptoms. But they don't always present like this. So any fever of any nature needs to be, you need to have malaria always in the back of your mind. Other things that they can present with is things like poor feeding or loss of appetite, severe headaches, which are often persisting and throbbing in nature, arthralgias, myalgias, lethargy, malaise. They can also present with coughs, GIT symptoms, so nausea, vomiting, diarrhea, and abdominal pain. And then other things like splenomegaly, which is usually in more patients who live in endemic areas. Then moving on to severe or the complicated form of malaria. Clinical findings, they may present with features of cerebral malaria. So this would be impaired consciousness or coma, prostration, which is unable to sit, stand, or walk without assistance, multiple convulsions, so that's more than 2 in 24 hours. They may have acidotic breathing and respiratory distress from the metabolic acidosis. They can also have circulatory collapse or shock, abnormal bleeding or features of disseminated intravascular coagulation. They can have features of black water fever, which is hematuria or anuria, so they may have then features of renal impairment. Clinical jaundice, but you must have evidence of other vital organ dysfunction. They can also have pulmonary edema or acute respiratory distress syndrome, as well as repeated vomiting is also can be a form of complicated malaria. If we look at special investigations, hemoglobinuria, so that was also black water fever, hypoglycemia, severe normocytic anemia, so an HB concentration of less than 5, or hematocrit of less than 15 in children less than 12, and in adults, a hemoglobin of less than 7 and a hematocrit of less than 20%, a metabolic acidosis, so a pH of less than 7.3 and a plasma bicarb of less than 15, hyperlactatemia of a venous plasma lactate of more than 5, renal impairment, which is another feature of black water fever, increased urea and creatinine, and then also hyperparasitemia, which I mentioned just now, how we see this on microscopy, but it's more than 250,000 asexual parasites per microliter of blood, or more than 4% parasitized erythrocytes. This is just a table to show what is more common in children versus adults. You can see there on the pediatric side, what's very common is convulsions, more features of the cerebral malaria, as well as neurological sequelae after cerebral malaria. And then also, very important to note, hypoglycemia needs to be, you need to check the glucose and treat as quick as possible. So moving on to diagnostic tests. It's important to note that the clinical presentation of malaria can mimic other diseases, so definitive diagnosis requires laboratory testing. And malaria is a notifiable condition, so as soon as the patient is tested positive, you need to notify. We've got two main types or ways of testing. The first one is our gold standard, so it's a peripheral blood smear microscopy. It involves a microscopic examination of a thick and thin blood smear. So basically, the thick blood smear is used to detect the presence of parasites in the blood, and then thin blood smear is examined to determine the species and the parasitemia, which is what I referred to earlier. Parasitemia is basically the percentage of the patient's red blood cells that are infected with malaria parasites. It's also important to remember that one negative test does not exclude the diagnosis. Non-immune individuals can be symptomatic at very low parasite densities, which may not be initially detectable. So if the patient has a negative smear and severe malaria is suspected, it's advised to commence therapy and then to repeat it 6 to 12 hours later. Other limitations of it is that it needs access to a lab with a microscope and staff that are trained to accurately pick up parasites on smear. The second one is a malaria rapid diagnostic test, which tests for antigens that malaria parasites produce in the blood. It's a very simple and fast way for healthcare workers to screen for malaria. And depending on a brand, it can give results in about 15 to 20 minutes. And then treatment can be started as soon as possible. It doesn't require any expensive or complicated equipment, but it is less sensitive than microscopy, and it cannot confirm each specific species of malaria or the parasite density, because depending on different brands, they test for different species. So for instance, the one that we have in the ED only tests for P. falciparum. So if the patient has a different species, they may not test positive. So I just want to go over how we actually use the tests in the ED. The one that we have is called the first response malaria antigen test, and it's kept in our doctor's cupboard that's close to the VBG machine. Basically, you assemble all the supplies that you need, which would be an unopened test packet, an alcohol swab, sterile lancet, buffer, a blood transfer device that comes in the box, which is a loop transfer device, a timer or a clock, and examination gloves. So firstly, to make sure that you need to check that the rapid diagnostic test has not passed its expiry date. Obviously, if it has, don't use it. Then if you look at the cassette, so there's a picture at the bottom there that explains the different holes and what you'll see on each one, or what you need to do on each one. So the square hole that's labeled A is where you add the blood. The round hole labeled B is for the buffer. And then on the left-hand side, there's a large rectangular hole, which is where the results will show. And this is divided into two sections. So the smaller section closer to the C will show the control line, so where the test is working correctly or not. A line must appear at the control line, otherwise the test is not valid. The larger section closer to the T is where you'll determine the diagnosis. So obviously, if a line appears in that section, it means that the patient has malaria. But if no line appears, it means malaria is not detected. Again, remember that this is only for P. falciparum, so it doesn't test for other species. Obviously, you clean a patient's finger, you prick it with a lancet, and you collect the blood. You place 1 drop of blood in the square hole labeled A, and then if you're using this first response malaria antigen test, you add 2 drops of buffer into the window labeled B. Then you set your timer for 20 minutes, and after 20 minutes, you can read the results. So a positive would mean 2 lines, so 1 at the C and 1 at the T. Negative would be 1 line at the C, but nothing at the T. And invalid would mean that there's no line at C or T, or no line at the C with a line at the T. So remember that the control line has to be there for the test to be valid. Moving on to management. So obviously in any patient that is severely ill, or any patient in general, we need to check ABCs. So airway, if the patient presents with features of cerebral malaria or depressed levels of consciousness and they are unable to protect their airway, we need to consider early intubation and then mechanically ventilating the patient. If they are having features, so breathing, if they're having features of respiratory distress, respiratory failure, or ARDS, we need to provide them with supplemental oxygen. And if they're not coping on supplemental oxygen, then we need to think about intubating and ventilating. Looking at circulation, obviously, if they have features of hypertensive shock, we need to put up 2 large bore IV lines. They may even need a central line for things like inotropes. And then we treat them according to our shock guidelines. But be very careful of overloading these patients as well, because then they can also go on to ARDS. Disability, so assess level of consciousness, pupils, features of raised ICP if they have cerebral malaria, and most importantly, we need to test and treat hypoglycemia. And then exposure, so obviously making sure that the patient is normothermic, and then also making sure that the patient will be respecting their dignity and keeping them covered up at all times. Moving on to investigations, so things that you would like to do in or the bedside, or most importantly in ED, so urine dipstick, looking for hematuria, proteinuria, and then doing a beta HCG to obviously check for pregnancy, because as I said, pregnant patients are at high risk for severe malaria. Doing a finger prick HGT, doing a VBG and ABG to look for metabolic acidosis, as well as hyperlactatemia, and then to do a rapid diagnostic test if it's available, as well as an ECG. And then we can also do a POCUS to look for features of hypovolemia, as well as features of a raised intracranial pressure, which would be an optic nerve sheath diameter. Then we can move on to laboratory tests, so things like an FBC, a differential white cell count, blood smear, and blood culture. These patients present in septic shock. So we also need to think about other other causes of the shock, not just malaria. So they can also have secondary bacterial infections. UNE, LFT, CRP, and then if you suspect DIC or abnormal bleeding, we need to do a PTT, INR, fibrinogen, and D-dimers. Radiologically, if they're presenting with respiratory symptoms, we need to do a chest X-ray, also after if they've had to be intubated, a CT brain if CNS symptoms are present, and if there's no features of increased intracranial pressure on CT or clinically, we can do an LP because we also need to rule out bacterial meningitis, which could also present with the same signs and symptoms. But obviously you need to check platelets because if they're less than 50, it's contraindicated. Then we need to start antimalarials as soon as possible, plus broad spectrum antibiotics if we're suspecting a bacterial infection. Control the convulsions. So according to our convulsion guidelines, we need to give benzodiazepines. If they've got severe anemia, so less than 7 in an adult, you need to transfuse with packed red cells. Pulmonary edema, things like raising head of the bed, high concentration oxygen, or ventilate if needed, and things like furosemide. Features of black water fever or renal failure, you need to consult the renal unit for possible dialysis. Important is monitoring urine output and fluid balance because they can be very under or overhydrated. And fluid overload can precipitate pulmonary edema and ARDS, but hypovolemia can then potentiate shock, metabolic acidosis, and renal failure. Reducing high fevers with antipyretics and non-pharmacological interventions, so things like removing blankets, cooling blankets, lavages, those kinds of things. Frequent monitoring of vitals, including HCTs, discussing with relevant specialities. So if it's a pediatric patient, peds, and obviously obstetrics if patient is pregnant, and then admitting to high care or ICU if there's available, because these patients need high-level monitoring. Moving on to specific treatment of malaria. So basically, if we look at uncomplicated or non-severe malaria, these are patients that are alert, can tolerate oral medication, and have age-appropriate levels of consciousness with no features of severe malaria. Obviously, we need to start antimalarials as soon as possible, and all first doses must be given under supervision, and patients must be observed for at least an hour as vomiting is common. So we have option 1, which is in uncomplicated low-risk malaria cases that are more than 5 kilograms. We give artemether-lumefantrine, which is also called Coartem. We need to give the first dose immediately and then follow with the second dose 8 hours later, and then 12 hourly for another 2 days, which is a total number of doses in 3 days would be 6. And at the bottom there, you can see a table that gives you the dose or how many tablets need to be given per weight. Option 2 is for children that are less than 5 kilograms with uncomplicated malaria. You use quinine, which you start and give it 8 hourly for 7 to 10 days. And then 2 to 3 days later, after starting the quinine, you can give clindamycin for 7 days. Children who are vomiting but don't have other indications of severe malaria can be given quinine IV until they stop vomiting. In complicated or severe malaria, children, well, actually all patients are given artesunate. It just depends on if they're less than 20 kilograms. We give them 3 milligrams per kilogram. If they are more than 20 kilograms, so including adults, it's 2.4 milligrams per kilogram at 0 hours, 12 hours, and 24, and then daily until the patient is able to tolerate the oral treatment. An alternative option, but this is only if artesunate is unavailable, we can give quinine IV. It's very important that you give this with dextrose containing solution because it can drop the glucose quite quickly. And we also need to do ECG monitoring at the same time. But then 2 to 3 days after initiating treatment with artesunate or quinine, the patients are able to swallow, then we can switch them to the oral regimens as above for the uncomplicated. Management in pregnancy. So pregnant women, particularly in the second and third trimesters of pregnancy, have higher risk of developing severe malaria and have a higher mortality rate than other adults. Maternal malaria increases the risk of spontaneous abortion, stillbirth, premature delivery, low birth weight, and congenital malaria. All pregnant women with malaria must be admitted to hospital, and those with severe malaria should be transferred to the highest level of care available. But management of malaria in pregnant women, so the medications as given above, is the same as non-pregnant adults. So how do we prevent malaria? So this is the ABCs of malaria prevention. Basically, we start with awareness and assessment of malaria risk. So this involves considering certain factors to decide whether it's safe to visit a malaria area or if one requires chemoprophylaxis. So factors would include things like time of year, length of stay, access to medical care. But pregnant women, children under the age of 5 years, immunocompromised patients, and splenectomized individuals are considered high risk and should avoid traveling to malaria areas at all costs. B would be avoidance of mosquito bites. So no antimalarial use for prophylaxis is 100% effective, but avoiding mosquito bites is just as important as giving the chemoprophylaxis medications. Preventative measures and control programs for residents in malaria areas, such as indoor residual spraying and larviciding or draining potential breeding sites, is done in areas such as in Limpopo and Mpumalanga that have more endemic areas of malaria. But personal protection is very important when going to these areas because we need to prevent mosquito bites. So things such as remaining indoors between dusk and dawn when the mosquitoes bite more often, wear long sleeve clothing when going out at night, apply insect repellent to exposed skin, keep doorways and windows closed or covered with screens, and use things like mosquito nets. C is for compliance with chemoprophylaxis when indicated. So if an individual is traveling to a malaria area, it's important to determine whether he or she requires chemoprophylaxis. The decision to recommend chemoprophylaxis is complex and depends on the areas to be visited and the risk the traveler has of being exposed to mosquitoes and of developing malaria. I've got a table here that shows the 3 medications that are given or are in our protocol in South Africa. However, if I can just summarize it, doxycycline can be given to children above the age of 8 years and non-pregnant adults. Children above 11 kilograms and non-pregnant adults can also use atovaquone proguanil. And mefloquine can be used in children over 3 months of age or more than 5 kilograms and in pregnancy. However, currently there are no mefloquine containing products in South Africa. So basically for all those people in that category, there is no chemoprophylaxis. And there's also nothing to use for less than 3 months of age or less than 5 kilograms. So all these people that fall in those categories should not be going to these areas at all costs. D is for early detection of malaria. So early diagnosis is critical to survival. It's important to always have a high index of suspicion in patients with a travel history to any endemic areas that are showing signs and symptoms of malaria, and effective treatment. So malaria must be treated as a medical emergency. The sooner the effective treatment is started, the better the prognosis. Lastly, the future is malaria vaccines. So malaria vaccines have been in development since the 1960s with substantial progress in the last decade. In 2021, WHO announced that they were recommending the use of the RTS-S malaria vaccine among children living in sub-Saharan Africa and other regions with moderate to high P. falciparum malaria transmission. And then in 2023, they approved a second malaria vaccine for use in malaria endemic countries. Current malaria vaccines reduced uncomplicated malaria by 40%, severe malaria by 30%, and all-cause mortality by 13%. However, the use of malaria vaccines is being prioritized in 12 endemic countries that have the highest need until vaccine supply can fully meet demand. And that's the talk. If there's any questions, let me know. Otherwise, thank you for listening.